nerve pain. In the low back, it's often caused by a disc herniation, especially in a young person. One of the best non-surgical indications is a epidural steroid injection. In fact, having a disc herniation is maybe one of the best indications for that is a disc herniation with sciatica or nerve pain down the back of their leg or the side of the leg. I do it with using a special x-ray called a fluoroscope in a controlled setting of an operating room. There are some people that do it without anesthesia, but I think that the patient experience is better with using a short-acting anesthetic for a few minutes. I like to get the patient comfortable, put them in face down, and then use the special x-ray, a live x-ray, to place a small needle in the foramen of the nerve that's affected, most commonly the L5 and the S1 nerve root, and confirm that with a little dye to confirm that you have a good representation of the nerve, and then give them 2 to 3 or maybe 4 milliliters of a local anesthetic and a steroid. We use short-acting and long-acting steroids, and for most people it helps to use a long-acting steroid. It's a short procedure and tends to be pretty well tolerated and can be really helpful. It may not get the patient where they want to be, but it can give them a little relief and let them know that maybe it's going to be persistent if they do need a small procedure like a microdiscectomy. We also do a procedure to try and evaluate for sacroiliac joint, and we can put these small needles into the sacroiliac joint as well. That's the joint that forms part of the pelvis from the sacrum to the ilium, or the bone where people say when they put their hands on their hip, that's the ilium. And while it's a less common cause of back pain, we see it for patients that have inflammatory disease, and maybe after they have an operation or a fusion of their spine, they can develop arthritis in that as an adjacent segment or adjacent joint. And again, these are very short procedures. I prefer to do it with the patient under anesthesia so they don't experience the pain, especially if you have to move your needle around a little bit to get the joint space, which is quite important. And then we again use a dye to make sure that we're in the joint, and then give them a longer acting anesthetic, and again this longer acting steroid to see if it helps them. And finally, the last thing that we do, sometimes akin to a sacroiliac joint injection, is our medial branch blocks, or facet injections as some people know them. And in a similar fashion, we identify them by using the fluoroscope in an oblique position, and then put a needle directly into the joint and give them a little medication there, confirmed with dye, and then in the area where the nerve goes to that joint. And this can help identify or diagnose that this is where a patient's pain is coming from, and it can be therapeutic. For this gentleman I just did, he said that every time he had one of these injections, he got about a day of relief. And I'm just hopeful he has a little bit more before he needs to consider having a bigger procedure or an operation.